Hi, Benchwarmers.
Hi, Benchwarmers.
So today we're referring back to our social media only because we've had a lovely gentleman by the name of Jory Oram. Shout out, Jory.
Shout out, Jory.
Send us some questions, but we're probably going to focus more on one question in particular.
Yep. Great questions.
yeah.
We will get around to answering them all.
Yeah, I feel like they're more answered in social media maybe rather than, but this one in particular is probably
Pretty interesting, we thought.
pretty interesting and
Yeah.
something we probably want to talk about because I know you've dealt with meniscal.
Yep, so I have had meniscal injuries.
Yep.
I'm awaiting MRI imaging to check on the status of them,
righto.
actually. So,
Good to know.
because I've had one on each, surgery on one, then a new tear, and then just a tear on the other one.
Yep.
And so I'm currently getting them checked out. Not because I'm having any issues, but because I spoke to an orthopedic surgeon who comes into my work, and he literally said, I want to see how fucked up your knees are.
Oh, all right. Cool.
When we spoke about them, so
fair enough.
I'm waiting some imaging.
It's
and
nice
some
to
input.
know some.
Yeah.
Yeah.
Good.
Yeah.
Good contact.
Well, I know Jory's also had a meniscal, and that's probably why he's
curious,
asking.
yeah.
But do you want to?
So the question, it's a kind of couple-part question. So he says, meniscus injuries, how often do you see, we'll probably answer them separately because otherwise I'll get confused.
Yep.
We'll get confused.
ADHD,
I'll get confused.
yeah.
How often do you see patients coming back after surgery still having issues? And then would you recommend surgery just on the basis, in the basis of quality of life, or would you advise physical rehab best option? Should we start with what is your meniscus? I feel like
I feel like this is a fascia thing. I feel like you love. Is this another thing where you like to talk
fascia.
about? You take the lead.
Take the lead. So your meniscus is a crescent-shaped shock absorber in your knees. So you've got your medial and lateral, so like inside of your knee and outside of your knee. Shock absorbers. That's pretty much what they are.
Yeah, that's pretty shame. I was actually expecting you to go on this tangent about a meniscus.
I could talk more about it.
No, that's fine. Well, we'll go on a tangent about
there's different types of tears. We'll probably go on the tangent when it comes to that.
Yeah.
I don't think this is a straight cut answer.
It's probably more about our own experience as physios if we've seen that occur. But to be fair, I really haven't seen it occur too much. Having it, because I haven't actually seen too many surgical repairs
From meniscus? Okay, I've seen a few.
Seen a few.
Yeah, I feel like there's, I've seen a few different types.
Sorry. From a young, but then later on, injuries,
So I guess we now know what your meniscus is. There's different types of tears, so you've got different areas of healing. So I think a lot of what you'll do, whether or not you go surgery or non-surgical, is based on the type of tear and also the zone, basically, in which the meniscus is torn. Typically, your meniscus is torn in like a flex knee position with like an impact, so like mostly falling on a bent knee is kind of how it's done, but also like pivoting movements can do it as well. So the different zones, basically, you've got your red zone and your white zones. The red zone's the outer third, white zone's inner two-thirds.
Quick math.
And basically, it's just about how they heal. So your red zone has blood flow. It's called your red zone because it has like a better blood flow to it, which means it has higher potential for healing. White zone, not as much. Basically, beyond the age of 30, the white zone increases. And so typically people over the age of 30, if you have a meniscal injury, the chance of it healing reduces. Yeah. You can have like red, white. This is the fascia part. You can have red, white tears as well. So it can kind of go beyond like from one area into the other. And then you've got different types of tears as well. So you can have like flap tears, bucket handle tears. I believe there's like parrot beak, kind of fancy names for all these things. Complex tears. The problem tears typically are like your bucket handle tears. So your bucket handle tears where you've got like your flap, it literally tears in like a bucket handle. And what happens is the issue is this section down the bottom here can basically flap, can move in and out and can actually cause a mechanical block inside your knee.
That's the symptom of like locking and you can't feel like you can't move your knee.
And so you've got two different types of locking, or giving way. So typically, like as a physio, you'll ask, do you have any locking, catching, clicking? Okay, people are always like, oh yeah, my knee clicks, and like that doesn't really matter unless you're getting pain with it, because it can be relatively normal for that. If you say yes, my knee locks, I mean, do you kind of have a pathway that you'll kind of go down in terms of like figuring out if it's more of a mechanical or a like pain provocation or giving way kind of locking, or what are you kind of?
So I agree. Like, in what situation does it lock, or how often does it lock on you, and all those kind of things.
Because a lot of times people will say like, yeah, my knee locks, and then it's like, okay, is it a true mechanical locking or is it giving way? And a true mechanical locking, to indicate like more likely meniscal tear, more meniscal injury, or like I guess an articular like loose body or something like that, is do you physically have to unlock your knee to get it to move again? It becomes fixed, it can't be straightened, you have to physically like maneuver your knee to get it unlocked. And when I was going for surgery, when I saw my surgeon for my meniscal injuries, I was having true mechanical locking. I remember running many times, and it was progressively worsening, where I'd run and I'd get, initially 20 minutes into a run, knee would lock, I'd bang the shit out of it, and then I'd be able to run again for a little bit longer.
Oh, wow.
And then over the course of 3 years of not having it, it basically would progressively worse. And I remember once I physically could not get my knee to unlock, and I remember having to like limp home. And then that's when I ended up seeing a surgeon, because it took like 3 or 4 hours to unlock my knee.
Unlock it, yeah.
Which was a bit scary. So how often, I guess then, there's so many questions. Surgery options. Yeah. You've got repairs and resections. So a repair is where they stitch you back up. Your rehab for that's normally a period of non-weight bearing, depending on the type of surgical approach. So they can do like, it's relatively new, I believe, but you can get like blood clots basically put there now, that you can walk with that, which is kind of interesting. Okay. I just learned about that a couple months ago maybe. Okay. But you can have a resection as well, which is where they literally just cut out part of your meniscus. And then your rehab for that is a lot quicker, but obviously the long term,
it's not great for you, because then you're just early onset like arthritis.
Quite a significant increase. So Jory's questions: how often do you see patients come back after surgery still having issues? Do you often see?
I don't know if I often, because like the ones that I've seen have been with ACL. And they're pretty good, to be fair. Like I haven't seen any, and they're young. So I haven't seen too many. I've had surgeons, maybe it's more in Toowoomba, where they've probably even gone against resections when they're a bit older. Just because of the whole idea of arthritis and whatnot. But they're still in pain. And I'm just like, well, how do we cope with this? How do we, so I don't know. I haven't really dealt with it too much. What about yourself?
I've seen quite a few repairs in younger and older populations. And then I've seen resections in younger and older populations quite a bit as well. I would say of the younger populations with resections I've seen, I have generally seen those patients again later down the track for a secondary knee injury. That's probably kind of the big things. I find the repairs in the older population, I think they tend to be slower, but I think that's just because it's a repair for one, which is slower.
What makes a surgeon decide between repair and resection? I
think
thought it would have to do with age.
Age does, healing, like from a healing side of things. But I believe it also has to do with what their lifestyle's like.
Okay.
So if they tend to be more active, they and I guess obviously at the end of the day, a lot of the time it's like patient choice as well. If they are aware of the risks of both, then I've found most people will go for a repair versus a resection.
Yeah.
They tend to go a little bit slower. I think they recover quite well. I'd say your biggest indication as to how well you'll go after is like what your pre-surgical form was like your physicality. That has a bit to do with it. But I think I've had a few like younger people who've had resections, and I would say most of them, or like a lot of times I've seen them, the first time I've seen them is after they've done their ACL or like their LCL or something like that, and they had a like a meniscal resection a few years prior.
Yeah.
So I think that's kind of a bit of an interesting trend. I don't know what the evidence on it actually is, but I definitely clinically I've seen that. And then...
Yeah. So how did you, like, because obviously you had the meniscal injury, were you going more trying to go conservative management where you weren't functionally, you felt like you were going okay?
Yeah.
But it just got to the point where you needed surgery?
For my surgery, it took a long time to get diagnosed.
All
that
right.
was kind of what slowed me down.
Yep.
So I actually tore my meniscus. So it was my right knee. I tore my medial meniscus. So I tore, I want to be specific, the distal horn of my medial meniscus. So essentially the attachment point. When I was 13, playing in a volleyball comp, swelled up the next day, massive balloon leg, massive amount of bruising through it. And then I started getting locking pretty much straight away. Was in a fair bit of pain. Knees used to swell like anything. And got X-rays, nothing came back. Got ultrasounds, nothing came back from that. Good old central Queensland where they were like, oh, you're having issues, let's send you for an X-ray. And then it was like, came back nothing. They're like, we'll send you for an ultrasound, came back nothing.
Okay.
Didn't actually have an MRI of my knee. So,
of course not.
Yeah,
of course not.
crazy. So MRI is the best way to pick
Gold
up.
standard.
Yeah,
Gold standard.
Yeah, ridiculous. And then after 3 years, basically was just getting progressive locking, worsening locking. All the time, was getting lots of pain, very frustrating.
Were you seeing a physio?
Nah. So lived out.
This
in
was back when you were quite young. No
physio. Literally got told by doctors and parents that they're like, the X-ray's clear. There's nothing wrong with your knee. You're all good. And then
is there an MRI machine in? There's probably not.
There's like not. I don't
You'd
know
have
if
to go to like Rocky or something.
Yeah. So that's
maybe
what
that's why. Yeah.
So there's no. So we got the referral to go to the X-ray. Went and got the X-ray in Rocky. So drove 2 hours to Rocky. Got the X-ray. Nothing. You're good. Same thing again. Ultrasound. Nothing. Yeah, you're good.
Yeah.
And then eventually, when my knee locked for the really long period of time, and it was progressively worsening. Like I used to run quite a lot, and it just was getting worse and worse and worse, happening a lot more frequently, becoming a lot harder to unlock, and pain and swelling were kind of the big things. And then had the big locking episode, and I was just like, this is ridiculous. Like, it's insane. I rang my parents because I was like, you have to come pick me. I can't. Like, I actually can't walk.
Yeah.
And I was like crying because I was just like so frustrated because it was just getting worse. And then eventually they took me to see a specialist in Rocky, and he did a McMurray's and a joint line tenderness test and was like, yeah, you need surgery. And then didn't get an MRI, which is wild. So your McMurray's and your joint line tenderness in combination still don't have a great sensitivity and specificity for meniscal. They basically will tell you something's wrong with your knee, but they're not.
Yeah.
Your joint line tenderness is, I think, the highest sensitivity and specificity of all of your meniscal tests, but it doesn't really give you much else.
Yeah.
Anyway, so then saw him on the Friday, and
this
then
is
got
wild.
Country Healthcare, and then got booked in on the Monday. He was like, oh, you desperately need surgery. This should have been fixed at 6 weeks. You're now 3 years down the track, so you need to come in 2 days.
Were you 3 years?
Yeah, 3 years with the
Oh,
meniscal
crap,
injuries.
righto.
Yeah, like long time. Yeah.
Mate.
And then he was like, you need to come in on Monday to get this fixed. Like, I'll put you before all of my other clients. And I was like, okay, like thinking, oh my God, my knee's gonna like fucking fall off or something. Yeah, and then, I mean, he was right. Like, I did have a meniscal tear, and it was a significant bucket handle tear. Anyway, he repaired it, didn't run me through any of the risks or anything. This guy is like renowned to not be a great surgeon now, which is funny. And then, yeah, had surgery. Wasn't told like non-weight bearing or anything. So I went back to work at I hopped off my crutches at about like 10 or 11 days, and then went back to work. I was in a ROM brace, which was locked, which was good. But yeah, and then went and saw him at 6 weeks, and he took the brace off, and I remember he gave me like some inner range quads, some static quads, and some knee flexion.
So was this a surgeon or a physio?
Surgeon.
Okay,
Yeah.
righto.
And then was like, cool, you're all good.
Go
Took the
see a
brace off.
physio?
Nah, none of that. This is your rehab, do this. And I was playing for Queensland volleyball at this point, so I was like, cool, I'm going to be playing volleyball soon.
Yeah.
And then...
That's hard, bro.
Nah, I didn't. And then did those exercises, honestly, for like maybe 3 or 4 days, because I was just like, and they hurt. They were hard. They hurt quite a lot. I remember they hurt quite a lot. And then I was just like, I'm not going to do them anymore. They hurt. They feel like shit. Don't actually think I ended up with full range back in my knee until like a year later when I was playing volleyball.
Yeah.
Because it was hurting to play. And I remember I took a dive and felt like a massive snap in my knee when I dove on it. And it swelled up a bit after, but then I remember being like, my knee can move now.
ACL's
Actually,
good.
yeah, ACL's good. No, I actually think I gave myself a manip. Like I manipulated my knee.
Yeah.
Because it was stiff. I remember it was stiff
as.
before, and then after that I was like, fuck yeah, I can move it freely. Wild.
That is wild.
It's so funny.
What a journey.
What a journey. So now I've had MRIs since then. Yeah.
So you being a meniscal expert now, what is the typical recovery after surgery? What should you brace?
Depends on the surgery, the type of surgery they do. But I would say for your typical meniscal repair, what they will do is you'll be in a ROM brace, so a range of movement brace. So basically, depending on the surgeon's instructions, you're normally straight for a period of time, and then you'll gradually add flexion into your knee. The big thing when it comes to meniscus, I would say probably one of the important things to tell patients or patients to know is there's a 6-week period typically where you are not allowed to go beyond 90 degrees. And that's because your hamstring attachment into your meniscus, if you go beyond 90 degrees, what it actually does is it moves your meniscus, which can rip the stitching apart. So there's normally 6 weeks of strict beyond 90 degrees. So you're normally in a brace for 6 weeks, and then progressive weight bearing. So sometimes they'll be non-weight bearing for those 6 weeks. Other times they'll be progressive weight bearing. I've had a few where they're a little bit more, you'll get a little bit faster nowadays, and you'll normally be fully weight bearing by 6 weeks.
Yeah. But the surgeons generally let you know.
They'll tell you what they want,
and surgical procedures and
exactly.
whatnot.
Your resection that you can pretty much weight bear as tolerated, basically.
Yeah,
so it's
because
there's no structure to protect, really. So would you recommend surgery just on the basis of quality of life, or would you advise physical rehab as the best option? Do you have something that you'd use to define?
I think it's it's very much the same with any kind of surgery option. It's functionally in pain. Are you able to function with your knee the way it is? And pain-wise, the way that you are. Particularly if you are an athlete, are you able to go back to sport relatively easy, or whatnot? If you're just in a admin job
you don't
kind
need
of thing, probably can do without. It also depends on obviously the level of tear.
Yeah, exactly.
It's
I think
all a bit individualised.
I'd say type of tear has the biggest influence on it. Because if you have true mechanical symptoms,
if you're locking,
that needs to be surgically repaired. That can't be managed conservatively. You've got a structural issue in your knee.
No matter how much strength we can do.
You need that. That needs to be repaired. In essence, I guess with that, the reason I'm having my knees MRI'd is because I have a complex distal horn tear in one of mine, and the other is a bucket handle tear.
Yeah.
So theoretically, based on my imaging that I've had 10 years ago, I should have symptoms of locking. And I did for about 6 months after I tore it.
Yeah.
Since then, over the last 8-9 years, I actually haven't had any symptoms of locking, and the orthopedic surgeon's just like, why the fuck not?
Yeah.
What's going on in your knees to stop that? Is it like the position of it fine or not?
And then say if you do want to conservatively manage it, do you do a period of non-weight bearing, or do you just go based off how they're feeling?
Symptoms, I'll go symptom management. So
if you can't put load on it,
then so meniscus themselves don't have nerve endings. So it's the lining of your knee capsule that is quite painful. So it's when there's the pulling and the swelling that's actually causing the pain. Your meniscus itself, you can basically cut into it with a pair of scissors and feel no pain. You will have swelling and those kind of symptoms, but pain is not related to the injury, that injury itself. So if people can tolerate walking, running, they can do it. That's fine, as long as you're not swelling or getting sore. That's typically how I'll base my rehab. And then lots of quad strengthening, hammy strengthening, calf strengthening. Obviously, depending on what they need to be able to do, if they're quite high athletic, they'll need to be able to do pivoting and things like that. Proprioception work is obviously really important as well.
You particularly want to look at biomechanics or whatever, and if they're knee valgus and whatnot, and that's probably why they might have had
exactly
things like that.
So I would say quality of life is kind of the big thing.
Because surgery has its own risks and whatnot. But obviously,
and you every time you're going into a joint, you're disrupting I guess the status of that joint, and the risk of developing arthritis is increased. As well as other complications, like you lose quad activation, which you have to kind of try to rebuild. Your proprioception's affected, which puts you at risk of more injuries or different injuries, and that's something you have to build up towards as well. So I would just say, like anything, it depends.
Yeah, definitely. I think Jory is at the moment, struggling with not playing because he's not playing volleyball and he's not playing rugby.
Yeah.
So I wonder if that's why he wants to discuss that, maybe the surgical options. Because I think his own physio has said that he shouldn't get surgery. But whether or not he might need to find second opinion. Or something.
I don't. I guess what's your opinion on physios' opinion sharing about surgeries?
I think you give your opinion, but then you also say, but I would maybe talk to your doctor as well, or talk to your family. And it's really based on what you think you need as well. Like I can understand from an athlete point of view why you want to get back into sport. Whereas I know some other physios, predominantly a lot of them are sport related, but some of them aren't. And so they might not understand that kind of idea of that's your whole.
That's what you do.
That's your life. And you might weigh up the possibility of having long-term issues with arthritis, but right now you could be doing what you want to do. I don't know.
I feel I don't mind people. I guess if you trust the person, appreciate their opinion, absolutely. But I feel like where I've been frustrated previously by physios is depending where they went to uni, depending what their life experiences, I was going to say expectancy is life, but that's not right. Their experiences are. I have had experiences where physios are like, don't do this, don't do this. And it's like, evidence actually says you can, or evidence says this. I get, I think, pretty most of my opinion, most of my opinion is based on, I would say, what evidence says. I really do try to be quite evidence-based in that it's, if you want to do this, evidence and research say this is the best outcome for that. Based on your type of tear, based on your expectations, based on your goals, this is what it is. And then also what I've seen clinically as well will come into it, and I'll say I've had a client who did this and this was their outcome, and they were quite successful. I think as well, getting people good surgeons as well, because, you know, I don't think as much in Brizzy, but, you know, some surgeons can be quite chop happy. And I've had like experiences with surgeons who have, you know, recommended a surgery. You know, I think people go into like, they see specialists because they're a specialist in this area, so they're going to give me the best advice. But some of them are very like, yeah, I can fix that for you.
Yeah.
Like without actually thinking about like what is the client goals. So I think like I would see a physio that you trust and get their recommendations and their advice on what specialist to see.
Yeah.
Because
do you have some in Brisbane that you kind of like, that's my knee guy?
Yep.
Yeah,
absolutely. There's also like in Bundy, there were people that we would, you know, I've actually got the name of this surgeon who deals specifically in this area. You have to travel to Brisbane for them, but I would recommend that you go see them, because some of the surgeons in Bundy are...
Well, are you going to finish that?
I would...
Butchers? No.
Yeah. If it was me, and that's the look, if it was me,
100%.
I would go see this person 100%. Because they're good at this. But I've got a few in Brizzy that I'm like, I know that this person is good for this, and I know that they are really talented in this area. Like again, Emma, like she fractured and dislocated her elbow.
Yeah.
And so I was like, you need to do this. Like, this is what you need to do. And so when I was talking to her about who to see, I was very much like, if you want the best advice and you want someone who's really evidence-based and is going to tell you the hard truth about it, and you don't mind if they're a dick, go see this person.
Yeah.
If you want someone that is more functional and more personable, but will still give you really good advice, go see this person.
Yeah.
And so I think that's okay as well, to kind of match up your specialists with your clients.
Yeah.
Or at least give them the forewarning and just say, this person is really fantastic, but their bedside manner's terrible.
Yeah.
Just so you're aware.
Yeah.
They'll tell you the truth, but don't go into it expecting to get on with them really, really well.
That's something, definitely when I moved to Toowoomba, I think I struggled, and I more so like talked to my colleagues about who they thought was best in Toowoomba and whatnot and certain things. So I think, you know, being a physio, you kind of need to talk to your colleagues or talk to other people and say, who
would you recommend with this person?
Who would you recommend? Yeah.
And I think having like, you know, I'm very fortunate in the position that I'm in now, where I actually get to meet quite a few orthopedic surgeons outside of work.
Yeah.
And so it's like I actually get to know them.
Yep.
You know, yes, I know them through their work and we get referrals to them through work, and I've, you know, met them all in professional settings, but I actually get to know them as people as well. And so it's kind of like you not only putting a name, like a face to a name, but you're getting to know that person and get a good...
of their bedside manner as well, a little bit, and understand how they might communicate with your patients.
And then you can kind of go, I think this person would go really well with, get really good outcomes, because a lot of like people's outcomes as well are, you know, it is based on if they trust a person. So if they trust their surgeon and if they trust their physio. And if they don't have that trust, they don't have as good outcomes. And language that people use as well is also really important in terms of quality of life. So like particularly, I know this is not meniscal related, but there's I've done a bit of research in terms of like hip replacements, and one of the best outcomes, like in terms of quality of life, people who have hip replacements and good quality of life, recorded good quality of life after, is actually more to do with what they're told they can and can't do, and limitations and risks, and just having good communication post-surgery versus the type of approach that they have. Which again is like kind of just interesting that it's like it's more to do with the rehab and their communication and their trust with people versus structurally the changes that happen.
I love a surgeon that'll actually send notes without me having to ask for it.
Yep.
I know some surgeons won't
Give you notes
unless you ask for it.
Yeah.
Which is always just a quick admin call, but
Yeah.
it's just like nice that like I see a patient.
Yeah.
Oh, there's
it's
already
almost like
notes
continuity of care,
Yeah,
hey? Where you're
yeah.
like, oh, this surgeon cares about their
there.
client.
Yeah.
Which I love as well. And
Yeah,
like
it's just
kind
that
of comes with a
communication,
plan.
yeah.
Because it's hard, like, you know, sometimes you get clients that come in that are like, oh, I've had this surgery and this is this is what I've had, and you don't have any information. And
Yeah, you're kind of going based off what they say,
Yeah.
and then sometimes it doesn't
It's not-
really.
it's not
It's what
always
they
accurate.
think, yeah,
And
yeah.
it's hard as well. Like, I remember thinking, like, you know, ages ago, I was like, oh, this, how could you not know what surgery you've had? How could you not know what surgery you've had is like a basic thing. But then when I had my ankle surgery, I remember, like, as a physio, that was like literally 2 years ago. I remember I went to my physio after, and he's like, so did you have the like syndesmosis stabilization? And I was like,
What?
I think so.
Well, to be
Pretty
fair,
sure.
that's like,
Yeah.
you know, latest. Like, for instance, like the difference between repair and resection. Some people might just hear meniscal surgery.
Yeah, I've had patients like that where they're like, oh, I had my meniscus done. And you're like, great, did you have a repair or resection?
Yeah.
Totally different rehab.
Yeah,
and they're
yeah.
like, oh, I don't know, they just did something to my meniscus. And
Yeah,
you're like,
exactly.
okay, so you've got this and you've got this. Do either of these sound familiar? And they're like, oh, I don't know what I had done. And you're like, okay, I'm going to like ring the surgeon to find out.
Yeah.
Purely because you can either be fully weight bearing with no limitations, or you could potentially be non-weight bearing in a straight ROM brace.
Yeah.
Like, and I don't want to be the one to fuck up their knee.
Yeah, exactly right.
'Cause it's
yeah.
like, I'm not going to do that
Yeah.
to a person.
Yeah.
So, funny.
Yeah, it is funny.
Weird time. So,
yeah.
did we answer all of Jory's questions?
Did we actually?
I think we might have. What
Is
did we
there
say?
anything else that you want to
Meniscal
talk
injuries.
about meniscus because you love talking about those
Fascia
kind of
and
things?
meniscus, like such a noob.
Should we, if we don't have anything else, he actually has a from the bench story.
He does have it from the bench story.
Should we
Yeah, we should
discuss
do that.
it?
I can't think of anything else I want to talk about meniscuses at the moment.
Okay, cool.
If you have any questions about
Meniscus,
shoot 'em.
Meniscuses. Don't know.
your medial or lateral meniscus,
Yes.
send them through.
Send them through.
So we've got injuries. So he said, I broke someone's leg in rugby. I had a mini stroke or something just then. I tackled this man in a ruck with my head next to his leg. Leg went backwards, body going forwards. I heard each crack, pop and gristle and still haunts me now. Also witness a fractured skull from wrong head placement in a tackle. Funny injury. Oh, we'll talk. Yeah,
Oh,
this is a funny injury. Separate.
also-
Did I say that I saw some guy's jaw break last time?
Yeah.
Yeah.
You've said it like 3 times.
It's fucked up. Literally the crack is like crazy. Funny injury. I almost lost my hand. What?
Yeah.
Whilst taking my shirt off and getting caught in a thin metal ceiling fan. Oh. Jory, you got to give us more details on that. Like
I
when
feel
you say
like I've done that before though,
I
because you
have-
just forget how
I
tall
have-
you were.
Yeah, I have that same issue. I have definitely played a game where I have stuck my
Oh,
hand
Hannah.
in and done like the
Yeah.
make music basically.
Yeah, fair enough. Oh yeah, that's
Was
true.
it? Yeah.
What are you gonna say?
I don't know.
He was literally trying to put his shirt on.
Were you
and then he
there?
just, no, I wasn't there.
Oh.
But I'm just imagining. I don't know what you're not understanding. Sorry. But like, that is quite funny.
A thin metal fan.
I'm wondering if there actually was a
I want
cut.
to know where. Yeah,
or,
like
or he just realised that
Yeah.
he went, oh, sugar.
yeah, like what
Yeah.
happened?
Yeah.
Yeah.
That is
He
pretty
says he
funny,
doesn't like
Jory.
ceiling
That's pretty
fans. If you
good.
know, you know. That's fair.
Yeah.
I actually have a fear of ceiling fans sitting under them, in
They're
case
gonna
they're gonna
fall?
fall on
Oh my
me and like
gosh,
chop my
yeah.
leg off or something.
Like an irrational fear, but it's not. I
What
don't know
if
if
it
it's an
does happen,
irrational,
though?
but it could happen. Yeah, definitely. Also, if it's making noises, if it's like cling, 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 and I'm like, that's gonna fall. That's gonna fall.
I've literally never heard that.
No, but like when a fan like makes lots of. Have you not lived in an
No.
old house?
I
Okay.
have, but not with
Not
ceiling
with-
fans.
Yeah,
I don't
but
think.
some of them wobble when
Oh,
they're
I've
going
had the wobble
fast.
ones where they're like this.
They're going like
They wobble? Yeah.
Yeah, that's concerning.
That's
I'd
terrifying.
rather not have the fan on and just lie
Die.
in my sweat.
Yeah.
Then yeah.
That's horrifying.
But thanks for that, Jory.
Yeah, thanks for that.
Oh my gosh, you created a whole podcast
based on this.
Yeah. What a guy. And he still has some questions there.
Yeah,
so
we will
if you
get around to answer
guys want to
them.
have some praise, like send us some questions on what you want, like injuries in specific. If you've got an injury and we can talk about it, like that's like we can do that. I don't care.
It'd be fun.
Like, that'd be nice.
Yeah. Please send us your injuries, funny injuries.
And if you want to know anything about
anything in particular, like where I feel like nerd out over like chats about stuff.
We nerd out. we will. Yeah, for sure.
We nerd out.
Yeah, we nerd out.
Yeah.
But thanks guys. Thanks to Jory.
Thanks, Jory.
But see you later. Bye.